You know that sound. It's not the steady, rhythmic beep of the wall monitor that you kind of just get used to.
Oh, the transport monitor.
Yeah, exactly. That really high-pitched, frantic chirping sound coming down the
It
hallway.
is quite literally the sound of adrenaline. It just cuts right through all the background noise of the unit.
It really does. Because it signals that those double doors are about to swing open.
Yeah.
And you are about to receive a human being who, usually less than an hour ago, had their heart completely stopped.
Right. I mean, their chest was cracked open. They were put on a bypass machine, cooled down, sewn back up, and then restarted. It's incredibly intense. Organized chaos, really.
Organized chaos is the perfect way to describe it. And now they are rolling into your unit. The room is cold, people are shouting out orders, lines are completely tangled.
Welcome to the CVICU.
The cardiovascular intensive care unit. And today, we're actually focusing on what is arguably the most dangerous time in that patient's entire hospital stay.
The first 6 hours.
Exactly. We are doing a deep dive into the CVICU Immediate Post-Op Open Heart Protocol. This was developed by Timothy Simpson, a CCRN, and the goal we have for you today is pretty ambitious.
Yeah, we aren't just sitting here reviewing a checklist.
No, we want to change the way you actually look at that monitor. We want to take you from being a reactive clinician, someone who's just chasing alarms, to being a true hemodynamic strategist.
That distinction is huge. It really is. Because if you're just chasing alarms in the CVICU, you are already losing.
Right.
The physiology of a post-pump heart is so specific and, frankly, so fragile that if you wait for the blood pressure to totally tank before you take action, you might not get it back. You just have to be proactive.
So let's get strategic.
Okay.
Subverse Material makes this really interesting point right off the bat, which is that the protocol doesn't actually start when the patient hits the bed.
No, not at all. It starts when you get the call from the operating room.
The handoff.
Right. You have to know the story before the patient even arrives. I always tell newer nurses, you need to build a mental model of exactly what is coming through those doors. If you wait until you see the patient to start thinking,
You're behind.
you are 10 minutes behind. At least.
So what specific intel are we hunting for on that call? I mean, beyond just knowing it was a bypass surgery.
You need the dirty details. First, you absolutely need the times. Clamp time and pump time.
Okay, we had...
How long was the aorta clamped off? And how long were they actually on the cardiopulmonary bypass machine?
Why do those specific minutes matter so much to the person receiving them at the bedside?
Because the bypass machine is traumatic. I mean, it keeps them alive, sure, but the longer a patient's blood runs through all those artificial plastic tubes, the more profound of an inflammatory response you trigger in the body.
Oh.
A long pump run means a much crankier heart.
And what does a crankier heart translate to clinically?
Usually profound vasoplegia, that's where the blood vessels are just wide open and leaky because of that inflammatory storm. Or, and this is equally bad, you're looking at severe bleeding issues because the patient's platelets have essentially been chewed up by the bypass machine.
Okay, so you get the times.
Yeah.
And you also need to ask about the wean.
The wean is everything. When they finally turned the bypass pump off, did the patient's heart just roar back to life? Or did it sputter?
Do they have to shock it?
Exactly. Did they have to max out the drugs just to get it to squeeze?
Because that tells you who your enemy is.
Yes.
If they struggle to come off the pump, your enemy is likely pump failure.
Yeah.
But if they came off easily, yet the surgery took 6 hours, your enemy's probably bleeding. Or vasodilation.
You're setting your radar. You are literally asking yourself, what is going to try to kill this patient in the next 20 minutes?
So you've got your intel. You're mentally prepped. The doors fly open and the team rolls in. This is the moment that's usually described as the swarm.
It is intense. You've got anesthesia at the head of the bed. The surgeon might be barking out orders. Respiratories reaching over you to grab the tube. It is so easy to get tunnel vision.
Simpson calls this the door check.
Yeah.
And he really emphasizes that this is not about perfection yet. It's about survival.
Right.
So what are the absolute non-negotiables in these first, say, 5 chaotic minutes?
Airway is always first, obviously.
Right.
You have to check the endotracheal tube depth immediately. Patients get jostled and moved around during transfer.
So the tube shifts.
Yeah, that tube can slip right down into the right mainstem bronchus, which effectively shuts off the left lung entirely.
So you're listening for bilateral breath sounds right away.
Immediately. If they aren't ventilating, honestly, nothing else matters. But once you know air is moving, you have to pivot straight to circulation. And this right here is where I see people make the single biggest mistake.
What's the mistake?
They trust the monitor blindly. Yeah, you hook up the arterial line cable, you look up and see a number, say 80/40, and you just start treating it. You absolutely cannot do that.
Why not? I mean, it's an invasive arterial line. Isn't it supposed to be the most accurate thing we have?
It's only accurate if it's properly calibrated. Remember, you just physically moved the patient from a bed to a cart to another bed. The transducer, that little tiny device on the cable that actually reads the physical pressure, it might be dragging on the floor.
Oh, wow.
Or it might be taped up to the IV pole 3 feet above the patient's heart.
Physics time. So if the transducer is down on the floor.
Gravity adds pressure to the reading. The fluid column is heavier, so your monitor will show a falsely high blood pressure. You might be standing there thinking the patient is totally fine or even hypertensive while they are actually crashing in front of you.
If it's too high up.
Then the pressure reads falsely low. You might look at the screen and start blasting them with pressors they don't even need, which can be disastrous. So the absolute rule is level and zero immediately.
So you need a baseline of truth before you touch a single drug.
Trust but verify. And heavy on the verify.
Okay, so the lines are leveled. We're verifying. What about the rest of the physical setup? The plumbing.
You're doing a very rapid visual and physical sweep of the hardware. Chest tubes, are they open? Is the suction actually turned on? I have seen cases where the suction was clamped for the transport and then in the chaos, nobody unclamped it. That is a straight recipe for tamponade.
We definitely going to get into tamponade later, but yeah, that sounds like a massive disaster waiting to happen.
It is. After the tubes, you check the pacer wires. Are they physically connected to the pacing box? Is the box even on? Does it have a working battery?
It sounds so basic.
It does sound basic, but in the heat of the moment, these are the exact things that get missed.
So the patient is officially transferred. The OR team leaves and the room sort of settles down. Now it's just you, the patient, and the wall of numbers.
The matrix.
Right. You got MAP, CVP, CIO, SVR, SVV. I mean, strictly speaking, it's complete data overload.
If you don't have a reliable system to decode it all, you will just end up staring at it.
The protocol suggests a great framework to simplify this. It distinguishes between the target and the tools. Can you break that down for us?
Sure. The target is usually the MAP, the mean arterial pressure. That is your general proxy for organ perfusion. It tells you, is enough raw pressure getting to the brain and the kidneys to keep them alive right now?
Okay, so the MAP is the scorecard.
Right. But the MAP doesn't tell you how to fix the problem if the score is bad. That's where your tools come in. And those are primarily your cardiac index, or CI, and your systemic vascular resistance, the SVR.
This is where the detective work really starts, because the source highlights two major clinical scenarios that actually look identical on the surface: low blood pressure, but they require completely opposite treatments.
Yes. This right here is the core skill of a CVICU nurse, differentiating vasoplegia from pump failure.
Let's start with the vasoplegia. This is what's often called warm shock.
Right. Exactly. Remember what we said about the bypass machine causing extreme inflammation?
Right, it makes the blood vessels dilate.
They get loose and floppy. So the clinical picture looks like this. The patient is hypotensive, the MAP is low, but, and this is key, their hands and their feet are warm to the touch. They might even look pink.
And if you look up at the advanced hemodynamic numbers,
You'll see a wide pulse pressure. That's the gap between your top systolic number and your bottom diastolic number. So maybe they are 90/30. That's a gap of 60.
and what about the cardiac index?
The index is usually completely fine. The heart is actually pumping away. The pump is working perfectly, but the pipes are just too wide.
So if a novice nurse sees that low blood pressure alarm and just immediately thinks, well, pressure's down, I should give some fluids.
You're just pouring water into a bottomless bucket. The patient does not need volume right now. They need their pipes tightened up. They need a vasoconstrictor like norepinephrine or vasopressin.
Okay, now flip it. Let's look at scenario B, pump failure or cold shock.
This one is scary. The patient is hypotensive again, but this time they are cool to the touch. They're clammy, maybe a little pale or gray, and the pulse pressure is very narrow, maybe 80/65. The numbers are squished together.
And the cardiac index here.
It's basically in the gutter, usually less than 2.0. And because the heart isn't pumping blood forward efficiently, all that blood backs up into the system. So your filling pressures, your CVP, or your pulmonary artery pressures are going to be high.
Let me summarize that. Cold patient, narrow pulse pressure, high filling pressures. The pump is failing.
Exactly. Now, if you give this patient a fluid bolus just because their MAP is low, you are going to drown them. Their weak heart cannot handle the volume it already has. You will push them right over the edge into pulmonary edema.
That is such a critical distinction. It's the exact same low blood pressure warning on the screen, but two completely different physiological realities. One needs a pressor to squeeze the pipes, the other needs an inotrope, a squeeze drug for the heart itself, like epinephrine or murinone.
And that is exactly why we say you cannot just treat the MAP. The MAP is the what, but the index and the SVR give you the why.
The protocol actually lays all of this out in a sort of if-then mental flowchart. Let's walk through a quick drill. You're at the bedside, the alarm goes off, the MAP is 55. Does panic set in?
No panic. You trust your process. Step 1 is always validation. Look at the arterial line waveform. Is the patient just bending their wrist and kinking the catheter? Did the transducer fall off the bed?
Let's say you check and it's real. The waveform is crisp, the MAP is genuinely 55.
Okay, we reach a fork in the road. First thing, I look at the patient. Are they warm or cold? Then I look at the monitor. Is the index high or low?
Let's say they are warm. The index is 3.0, which is totally fine, but the SVR is completely tanked.
Classic vasoplegia. I'm either starting or aggressively titrating my Levophed. I need to tighten those pipes up now.
Scenario 2. The patient is cold, the index is 1.8, which is bad, and the CVP is steadily rising.
The heart isn't squeezing. I'm notifying the provider immediately. We need inotropic support. We need to whip the horse, so to speak, to get that cardiac output up.
But there's a third path in this flowchart too, right? The empty tank.
Yes. Plain old hypovolemia. This is the scenario where absolutely everything is low. Low MAP, low index, low CVP. The patient is just dry, or they're bleeding.
And this is the only time you just freely give fluid.
Well, freely is a very strong word in cardiac care. You give guided fluid, very careful, small boluses, usually 250 milliliters at a time, and you watch the heart's response. Does the stroke volume actually go up? If yes, you can give a little more. If the pressure just rises but the actual flow doesn't improve, you stop.
I really want to zoom in on something you mentioned earlier, the plumbing. Because there is a very specific mechanical disaster that just haunts the CVICU, and that is tamponade.
It is the silent killer. The source material is extremely clear on this point. Post-cardiac patients can absolutely bleed, but the true immediate danger is when that blood gets trapped inside.
So we obviously watch the chest tube output constantly.
Obsessively, you are checking it every 15 minutes for the first hour or two. If you see bright red blood suddenly pouring out, say, 200 or 300 mLs in just 15 minutes. That is active surgical bleeding. That is a go back to the OR right now situation.
But tamponade is trickier than that. It's what Simpson calls the tamponade trap.
Right. Picture this scenario. Your patient has been bleeding a steady, predictable 100 mLs an hour. Then suddenly it stops. Zero output.
I feel like a novice might look at that and think, oh, great, the bleeding stopped, we're good.
And an expert looks at that and thinks, oh no, the tube is clogged. Because if that blood is still actively leaking inside the chest cavity, but it can't get out through the tubes, it starts filling up the pericardial sac, the tight space right around the heart.
And as that space fills up with fluid, it squeezes the heart.
Exactly. Quite literally strangles the heart. The heart physically cannot expand to fill with blood, so it has no blood to pump out.
What does that look like on the monitor before it's too late?
It looks a lot like the cold shock we talked about earlier, but it happens much faster. The blood pressure starts to drop. The CVP, your filling pressure, shoots way up because the blood is hitting a wall and can't get into the heart. And that pulse pressure gets extremely narrow.
The classic tamponade sign.
Yes. If you see a sudden, complete cessation of chest tube output paired with new hemodynamic instability, you have to assume it's tamponade until proven otherwise.
And the fix for this isn't pushing drugs, right?
No. I mean, you can give a little fluid to try and push against the squeeze or a little epi to keep their heart beating, but the fix is strictly mechanical. You have to get that trapped blood out, and that usually means the surgeon is opening the chest right there in the ICU bed.
Which brings us back to the idea of prevention.
Mm-hmm.
How do we keep those tubes from clogging in the first place?
You have to be aggressive with them. Keep the tubes completely straight. No dependent loops.
No.
That means don't let the plastic tubing dip down below the level of the bed and then snake back up to the collection canister. Fluid can't climb uphill. It will just pool at the bottom of the loop and form a massive clot.
And what about stripping or milking the tubes?
You definitely need to follow your specific hospital policy, but generally speaking, yes. You need to physically manipulate those tubes to keep any early clots moving down into the canister. If you're passive with chest tubes, you're being dangerous.
And Obviously, don't wait for the patient to crash.
Never. You have to anticipate the need for blood products. If the lab values are starting to drift and the tube output is staying high, you order the platelets and the packed red blood cells before the blood pressure ever drops.
Let's shift gears slightly and talk about the electrical system, the rhythm. The protocol describes the post-op heart as irritable and stunned.
It is very grumpy. You touched it, you sewed it, you literally froze it with cardioplegia. It is not happy to be awake.
One of the big focuses in the text is maintaining what's called the atrial kick. Why does that matter so much right now?
So normally the top chambers of the heart, the atria, give a little squeeze, just a fraction of a second before the bottom chambers, the ventricles, squeeze. That initial contraction, the kick, actually pushes an extra 20 to 30% of blood down into the ventricles.
That's a significant amount of extra fuel for each pump.
It is huge, especially if the heart muscle is stiff and non-compliant, which it almost always is after surgery. If the patient suddenly goes into atrial fibrillation or AFib or a junctional rhythm, those top chambers just quiver. They don't actively squeeze, so you completely lose that extra kick.
And suddenly your total cardiac output drops by 30%.
Instantly. The blood pressure just tanks.
Yeah.
That is why we are so incredibly aggressive about keeping these patients in normal sinus rhythm.
And that's exactly what those temporary epicardial pacing wires are for.
Yes, use them. That is always my advice. Don't wait for the patient's heart rate to drift down to 40. If the patient is chugging along at 60 beats a minute but their blood pressure is soft, turn on the pacer. Drive them at 80 or 90 beats per minute.
You're essentially just overriding the heart's post-op sluggishness.
You're optimizing. You're guaranteeing a set rate, and you're forcing that atrial kick to happen. And you are also keeping the electrolytes, specifically potassium and magnesium, in the high normal range. A low magnesium level is basically a printed invitation for AFib.
Now, there's one specific chamber of the heart that gets a lot of special attention in this protocol. The right ventricle, the RV.
Ah, the poor RV. We honestly call it the wimp of the heart, sometimes the prima donna.
That seems a little harsh.
It's anatomically accurate, I promise. The left ventricle is super thick and muscular because it has to pump blood to the entire body. But the right ventricle is very thin-walled. It's only designed to pump blood right next door to the lungs and under very low pressure.
So it really can't handle stress well.
It handles volume okay, but it absolutely hates pressure. If the resistance in the lungs goes up for any reason, the RV dilates and fails very quickly.
And how do we accidentally raise the pressure in the lungs?
Usually with a ventilator. If we use too much peak positive end expiratory pressure, we are literally inflating the tiny air sacs in the lungs so much that we squash the tiny blood vessels the RV is trying to pump through.
It's like pinching a garden hose while the faucet is still on full blast.
Exactly. The RV tries to push against that pinched hose, it balloons out, and it fails. So protecting the RV means being very gentle with your ventilator settings. It also means strictly avoiding acidosis and hypoxia, because both of those things chemically cause the pulmonary arteries to constrict.
So in a way, managing the ventilator is actually managing the heart.
It is a totally closed loop. You can't just fix one thing in isolation. You tweak the vent too much, you kill the RV. You miss the low magnesium, you lose the atrial kick. Everything is connected.
As we start to wrap up this deep dive, I want to talk about the truth tellers. Because we established pretty early on that the arterial line can lie. You can have a perfectly normal blood pressure on the screen, but the patient is actually actively dying.
Yes, this is the concept of occult shock, hidden shock.
So what are the numbers that actually don't lie to us?
Urine output, your lactate levels, and your SVO2.
Let's break those down. Why urine output first?
Urine output is essentially the poor man's cardiac monitor. The kidneys are total divas. If they aren't getting excellent continuous blood flow, they just stop working immediately. If your patient isn't making at least 0.5 milliliters per kilo per hour of urine, they are not adequately perfused, regardless of what the blood pressure cuff says.
And lactate.
Lactate is the cellular byproduct of suffocation. When cells don't get enough oxygen, they switch to anaerobic metabolism and start pumping out lactic acid. It's often a little high right after surgery, but it should consistently trend down. A rising lactate means your tissues are literally starving for flow.
And finally, SVO2, mixed venous oxygen saturation.
This is genuinely my favorite number on the monitor. It measures exactly how much oxygen is left in the blood after it has circulated through the entire body and returned to the heart.
So if it's
It means the body is extracting every last possible molecule of oxygen because the delivery system is too slow. It is a massive supply and demand mismatch.
So here's the real nightmare scenario. You look up at the monitor, The MAP is 70. It looks perfect. But you notice the urine has stopped. The lactate has drifted from 2 up to 4, and the SVO2 is dropping into the 50s.
That patient is crashing. You just don't see it on the pressure tracing yet. That is the exact moment you have to act. You have to step back and ask, is this tamponade? Is it low cardiac output from the pump? Is it hidden bleeding?
You essentially have to ignore the good blood pressure and treat the bad perfusion.
Precisely. Do not ever be reassured by a green number on a screen if the patient's metabolic markers are screaming for help.
Which really circles us all the way back to the core philosophy of Simpson's protocol, staying ahead.
You have to think in systems. You evaluate the pump, which is contractility, the pipes, looking for SVR and vasoplegia, the volume, checking preload and bleeding, and gas exchange, protecting the RV and the lungs. You literally cycle through those 4 systems in your head every 15 minutes.
The source poses a really great question that you should be asking yourself constantly. What changed in the last 15 minutes?
It stops you from getting complacent. Did the pulse pressure narrow slightly? Did the urine slow down? Did their hands get cold? If you catch those subtle physiological shifts, you can fix them with a tiny nudge. But if you wait for the alarm to sound, you might need a sledgehammer.
It transforms you from just a passive monitor watcher into a true clinician.
That's the ultimate goal. The machinery in the unit is incredibly impressive, but the human brain connecting the dots is still the most critical tool in the room.
That is a very powerful place to leave it. For everyone listening, whether you're a brand new grad stepping into the CVICU or a veteran looking to sharpen your skills, remember, the monitor only tells you what is happening, but only you can figure out why.
And I'll leave you with one final thought to chew on. We focus so much on the high-tech gear, the Impellas, the balloon pumps, but if the numbers on the screen look totally fine while the lactate slowly rises and the SVO2 drops, what is the patient's body trying to tell you that the arterial line is hiding? The answer to that question is usually the difference between a save and a crash.
Thank you so much for that insight, and thank you to everyone for listening to this deep dive. Stay curious, stay strategic, and we'll see you next time.